I am going to talk to you all about lung cancer screening and approach to the lung nodule. I don't have any disclosures, but I do want to acknowledge Dr. Winehouse, my colleague, who has graciously allowed me to use several of his slides from past presentations. So the objectives of this talk are to go over the epidemiology of lung cancer, the objectives and the outcomes of screening, and the diagnostic approach to lung nodules and lung cancer staging. So lung cancer itself, as everyone might know, is the leading cause of cancer death worldwide. If you look at males and females lower down, there are about 21% of cancer deaths related to lung cancer. In the United States alone, there's an estimated 240,000 new cases each year. And each of them, in males and females, lung cancers are second only to prostate and breast cancer, respectively. 80% of the deaths are related to smoking, and only 20% of the deaths are in never smokers. Some additional risk factors that are associated with lung cancer include exposure to asbestos, radon, pollution, and other smoke exposure. Historically, lung cancer is very strongly linked to tobacco smoke. And interestingly, the rise in lung cancers, as you look at this dotted line, parallels the increase in tobacco smoking in the United States. And this is the mortality rates of lung cancer in males as well as females. If you look closely, in the 1900s, cigarette smoking had largely increased. It was being promoted in society, in the military. It was only in the late, in the 1950s, where epidemiologists very strongly proved the association between tobacco smoking and lung cancer. It was only in 1964 that the Surgeon General released his report saying that smoking is a public health hazard and we need to initiate public health initiatives. These initiatives eventually related to increasing the tax on cigarettes, banning smoking in public places, allowing nicotine replacement products to be available, slowly started decreasing the incidence of smoking, and thereafter you can see that the rates of lung cancer deaths also started falling. Only about 21% of lung cancers, unfortunately, are diagnosed at an earlier stage, and this has increased in the last 5 years. Unfortunately, 53% of lung cancers are diagnosed when there are already distant metastatic involvement. Unlike prostate, breast, and colon cancers, the overall 5-year survival for lung cancers remains pretty low at about 25%. And this rate is even lower in African Americans. If you look at this graph, regardless of the database, regardless of the type of lung cancer, you will see that the overall survival for early stage lung cancers is significantly greater than that of late stage lung cancers. For example, stage 1 non-small cell lung cancer has a survival of ranging from 53 to 89%, depending on the substage. And what this shows is that the stage at the diagnosis really matters, and early stage confers a significantly improved survival. And screening, therefore, is critical. Screening refers to testing of people at risk for lung cancer, but those that don't have either symptoms or signs of the disease. And the goal is to detect lung cancer at a stage when cure is possible so that we can reduce mortality. The ideal test is one that has little risk, not expensive, pretty sensitive, has few false positive results, and is acceptable to the patient and to the health system. If you look at the history of lung cancer screening, since the 1960s, ever since the link was exposed and the cases started going up, There have been multiple randomized controlled trials and other studies, observational, throughout the world, trying to figure out the best way to screen for this disease. Initially, chest X-ray sputum cytology were used, and then eventually in the 2000s, studies were done utilizing low-dose CT scans. So the initial studies utilizing chest X-ray and sputum cytology appeared to initially confirm benefit, but none of them actually proved a significant mortality difference, and therefore none of them were felt suitable to be used for screening. It was only in 2011 when the landmark study, the National Lung Screening Trial, or NLST, was published that low-dose CT scan was proven as an effective method for lung cancer screening. So our history of lung cancer screening is essentially only in the last decade or so. It was a prospective randomized trial of about 53,000 odd patients. And what they did is they split it into two arms. The screening arm utilized low-dose CT scans annually for 3 years, and the control arm was using chest X-rays. The endpoint was lung cancer-specific mortality, and the inclusion criteria included patients aged 55 to 74 that had at least a 30-pack year history of smoking or who had quit within 15 years. And what they showed is that there was a significant relative reduction of 20% of lung cancer deaths in patients in the screening arm with low-dose CT scan versus the chest X-ray arm. And 320 people needed to be screened to prevent one death from lung cancer. And you can look at the numbers, you need a much higher number to screen for breast cancer and colon cancer to prevent one death. And it was very clear that utilizing low-dose CT chest scans not only increased the detection, but also decreased the overall mortality. The next study that was a significant change was the Nelson trial. That was another prospective randomized trial. It was the second largest. It was sort of male-focused, about 15,000 odd people. And what they did is they included people with a lower cigarette smoking history, 15 years, more than 25, or over 10 cigarettes for over 30 years, quit within 10 years. And what they did is they randomized these patients to low-dose CT screening using volume at multiple years versus no screening at all. And they followed all these patients for at least 10 years. They had a pretty good adherence. The primary outcome was lung cancer-specific mortality. And what they found is that there was improvement in mortality in both men and women. Cancers were being detected at an earlier stage. And at 10 years in the follow-up, there was a significant decrease in mortality in the control group, in the screening group as compared to the control group. And this translated to a 26% decrease in mortality in men and a 39% decrease in women. And they also noted that volume CT screening led to fewer harms, decreased false positive, unnecessary workups without jeopardizing any of the favorable outcomes. And so if you look at screening guidelines, at least here in the United States, it only started after the NLST was published in 2011. A year or two after that, the United States Preventive Task Force issued its first screening recommendations. Soon afterward, the Center for Medicaid and Medicare Services started approving coverage for lung cancer screening. I also want to add that multiple societies, including American Thoracic Society, the Society for Surgeons, Family Practice, ACCP, a lot of them also endorsed lung cancer screening with low-dose CT scan and published their guidelines with their inclusion criteria. It was only after the Nelson study was published in 2020 that organizations started changing their inclusion criteria. USPSTF soon followed in March 2021, and they lowered the screening age to 50 from 55. And they also lowered the pack year history required to be eligible for screening from 30 pack years to 20 pack years. And this was significant because the catchment for these patients to be eligible was just broader. CMS followed in February of 2022 and they decreased the eligibility criteria in terms of age to 50. So their criteria are 50 to 77. Patients should be asymptomatic. They also lowered the pack year history to 20. In addition, CMS also mandated, and had always mandated, additional criteria to be used for screening, including counseling and a shared decision-making visit that we will discuss in future slides, as well as they had criteria on who could read such studies and where these studies needed to be performed for them to be covered. Most private payers were also on board by the end of last year in terms of these modified eligibility criteria. So what is the shared decision-making, and how do you utilize that in terms of screening? So the shared decision-making is an evidence-based risk-benefit discussion with the patient regarding screening, with decisions made taking into account the patient's values and the preferences. What's important here is that it's a patient-centered form of care and discussion, and the outcome is not the actual decision of the patient. So it's not that, oh, I had 10 people say yes to screening. The importance is that it's an informed decision-making process regardless of the outcome. And so importantly, in the shared decision-making process, the patient has to be informed of the pros of cancer screening that we've discussed, including improved diagnosis at an earlier stage, as well as decreased mortality, but also the cons that include false positive rates, overdiagnosis, misdiagnosis, the anxiety that goes along with finding something that's abnormal, the unnecessary potentially tests and other procedures that may accompany that, as well as the radiation exposure, and of course, importantly, incidental findings that are not small. And so the goal of the provider is to discuss with the patient and figure out where they are in the continuum of benefit versus risk and what the patient actually values. The other thing to think about is low-dose CT scans confers a radiation risk. If you look at the radiation that a chest X-ray gives you, it's about 0.1 millisieverts. A low-dose CT scan gives a patient a 1.4 millisieverts of radiation exposure, and contrast this to a diagnostic CT chest, which gives about 7 to 8 millisieverts. So what they calculated is, in the NLST, each patient that was being screened had, on an average, 3 CT scans and an average dose of about 4.3 milligray, and the lifetime attributable risk of lung cancer mortality from radiation alone, which is cumulative, was about 0.07% in men and 0.14% in women. There are many risk calculators and decision aids that are available to patients. I won't go through the details of this, but it is available. For patients, this helps them if you plug in several variables, their age, their risk factors, their smoking. It helps patients figure out what their risk of lifetime of lung cancer is and whether they're eligible for screening. This is just one website. It's shouldiscreen.com, created at University of Michigan. And these are just some examples of what patients can use. So in our fight against lung cancer, we have a few things to think about. One is, we already talked about earlier detection. It sort of goes intuitively that you have increased rates of screening, you can detect cancers earlier, and potentially they can be curable. The other strategy is, of course, improved treatment modalities, and a lot of research is going on in this realm to continue to improve the armamentarium that we have to allow improved survival and quality of life for these patients. The other big thing is smoking cessation. We know that it's linked to lung cancer, so therefore, if there are fewer smokers, there's potentially less incidence of lung cancer. Just a note on the US cancer screening rates. There's a significantly higher screening rate for cervical, breast, and colorectal cancers, and that's great. But unfortunately, we are significantly lagging behind. In 2015, only 4% of eligible patients were actually being screened for lung cancer. And unfortunately, even a few years later, that's still pretty dismal at 6%. So we have a long way to go, and we have a lot of work to do to try to improve our lung cancer screening. Just a note on smoking cessation, because it's so important. It's a teachable moment during the screening process. When a patient comes to you for screening or for other visits, that's the time that you can engage. They're engaged in the healthcare system, and that's the time to talk to them about smoking cessation. About 50% of patients who are enrolled in lung cancer screening are smokers. And the important thing is, once you stop smoking, usually within 7 years, there's a 20% mortality benefit. So if you look at it this way, a patient who's already enrolled in screening has a relative mortality reduction by 20%. And then they stop smoking, they have a mortality benefit within a few years. So imagine the increased benefit if you're enrolled in screening and you stop smoking. That's pretty, it's pretty significant. And so therefore, all smokers should be offered intervention. And, it's not easy. And so there are some training that's required for both the provider to effectively counsel patients. So why are we so poor at screening, and what are the barriers? Because unless we understand the barriers, it's going to be hard to overcome these and to improve our screening rates. A lot of this is because of lack of awareness. Some patients just don't know that there's screening available. Providers and patients alike may be unfamiliar with guidelines. There are challenges to access. People live in rural areas that are not close to centers that offer screening. There are difficulties with the shared decision-making visit. It takes time. It's hard for a provider who's already only having 15 or 20 minutes per patient to engage in that. There's also perceptions and fears on the patient's part. They don't want to know that they have something wrong. So maybe just not have the CAT scan. You won't find anything. Cost of CAT scans, some patients have a hefty copay. I have patients who tell me that, order it in January, don't order it now. Managing abnormal results can also be significant because now the CAT scan picks up many things. So multiple disparities, barriers that we have to look into. The other thing is disparities in screening. As you can imagine, the NLST criteria is a one-size-fits-all. So you have your age, you have the amount of smoking that patients need to have, and then you have the number of years within which they have to quit. But we don't take into account that there are variations. There are multiple disparities. African Americans have a higher lung cancer risk, and that occurs both at an earlier age and with fewer years of smoking. Certain ethnic groups have a lower or higher rate of smoking, of risk of lung cancer. Women are at higher risk of lung cancer, even if there's a variation in their smoking practice. HIV confers an independent risk for lung cancer. And other risk factors such as literacy, where the patient lives, all that makes a difference in their access to screening and in lung cancer risk. And smoking behavior itself, there are higher intensity smokers that smoke heavier, and they're at a higher risk than lower intensity smokers. There are multiple factors that go into disparities that, eventually we need to talk about more. Unfortunately, the screening guidelines do not consider these at this time. Also to talk about outcomes. So Dr. Silvestri and his group published the outcomes after the first 1 million people were screened for lung cancer. And what they found is that the overall cancer detection rate was about 0.56%, while 82% or so patients had negative results, 17% had positive screening results. And the big thing was that there was a significant shift towards earlier stage lung cancers, which is huge and which is the goal of screening. About 53% were early stage. Unfortunately, there was a very low adherence to screening. Only about 22% of patients were adherent to their annual screening. And some of this relates to they're still smoking. They may not want to have that counseling. There are racial and education factors and insurance factors. So it is true that only about 27 to 30% of lung cancers would be detected if all eligible patients were to undergo lung cancer screening. There's and that's only the tip of the iceberg. There's a huge number, about 70% of people who are ineligible for screening who still get lung cancer. And so biomarkers are being looked into. They're already there. There are about 3 biomarkers that already exist in the market that look at various autoantibodies, various proteins that try to stratify the patients who may not be eligible for screening, but who still have a higher risk, or who are already eligible, but we need to risk stratify them a little bit better. And these markers try to help, are helpful in high risk and low risk patients. So what can we do better in terms of screening? I think over time, we should try to optimize our selection of patients based on their individual risk. And I know there are many people looking into this. We have to try to overcome our barriers, address and improve disparities, try to decrease the radiation risk further if we can, and improve patient and provider education. So in summary, lung cancer screening with low-dose CT scan improves mortality. Screening is recommended for select patients meeting criteria and at a center with an infrastructure supporting a screening program. Smoking cessation counseling is a key component of a lung cancer screening program. And we need better strategies for overcoming several barriers and disparities in lung cancer screening and improving poor adherence rates. So now, just to make sure that everyone's awake, we have a question. So I'm going to read the question out and then I'll ask for a show of hands. A 66-year-old asymptomatic smoker who smokes 1 pack a day for the past 45 years with a history of severe congestive heart failure should be counseled on the importance of smoking cessation and A, should not be considered for lung cancer screening, B, undergo a yearly CT scan of the chest, C, undergo an initial chest X-ray and sputum cytology, D, screening should be considered, but may not be advisable based on potential severe life-limiting comorbidities, and E, undergo an initial regular diagnostic CT scan of the chest. Anyone for A, B, C, D, or E? I think the majority of you did pick D, and that is the right answer. And the reason is because it's just another thing. When you have a severe life-threatening or life-limiting comorbidity, you really have to weigh whether screening is going to actually add to benefit or not, or if your other comorbidity is going to get you sooner. So now that you've undergone screening, and you may be the provider that single-handedly increases the screening rates in your state, and you have a screen positive CT scan, what do you do? How do you manage that? And so the questions that come up when you have a lung nodule that comes up is it malignant? What are the characteristics of this nodule that are concerning? What are the follow-up guidelines? Would you choose to biopsy? And if so, how? And should you stage the mediastinum? And what are the staging modalities available? How do you help this patient further? So when you look at the differentials of a lung nodule, it's not just malignant, but there's a huge host of things this can be. A lot of them are benign. There's a huge number of infectious disease processes that can manifest as a nodule, inflammatory conditions, benign tumors, and of course, malignancies, which is what we are most concerned about, and several malignancies as well as lymphomas. So the key thing is to look at patient characteristics, looking at the age, the demographics. Are they older? What is their smoking history? Do they have other exposures? Do they have passive smoking exposure, radon exposure? Do they have a family history? A family history of lung cancer is a risk for lung cancer. And do they have other malignancies? Could this nodule be a metastatic nodule? And then you look at the nodule characteristic itself, and we'll go over some of these in detail. What kind of nodule is it? What is the density? Is there only one? Is there more? Is there intrathoracic lymphadenopathy or extrathoracic lesions that make this overall a higher suspicion for malignancy? And looking at the nodule, size matters. A nodule is anything that's less than 3 centimeters, and a mass is defined as something that's greater than 3 centimeters. And if you look at the prevalence of malignancy, it definitely increases as the size increases. And once you get to over 3 centimeters, you have a 90+% prevalence of malignancy. And if you look at just yield based on conventional bronchoscopy without advanced techniques, you have a higher yield as you get over 2 centimeters. Nodule characteristics and the density also is important. When you have ground glass lesions, it can be inflammatory or adenocarcinoma in situ, which would be our concern. As you start getting more solidity in the nodule, that just indicates invasiveness, and the risk is higher for solid nodules, and the risk, of course, is based on size, as we just discussed. Borders can also be important. If you have an irregular, a spiculated, or a lobulated nodule, that's a higher risk for malignancy. Usually, smooth and well-defined borders indicate benign nodules. That said, a carcinoid, it would be an exception. Calcification patterns can also give you a clue as to the risk of malignancy. Usually a central or bullseye or diffuse or a laminated pattern or a popcorn pattern are all indicative of benign lesions typically. When you have scattered punctate or eccentric calcifications, that usually indicates a higher risk of malignancy. The location of the nodule matters. In the Nelson trial, they noted that about 62% of malignancies occurred in the outer 1/3 of the lung. And there was definitely a right upper lobe predominance, presumably because the upper lobes are better ventilated. The growth pattern also matters. The volume doubling time is typically used to indicate growth of lesions. And what I wanted to point out is we often use linear measurements. So for example, if a nodule increases from 8 millimeters to 10 millimeters, it might seem like a very small increase, but that nodule has just doubled in size when you look at volume. And so you look at the patient characteristics and the nodule characteristics, and you try to put people in buckets. So do they have a low risk of cancer based on all of these characteristics? And that's less than 5%. Those are younger people without significant smoking history and based on the nodule characteristics. Or you may have people in very high risk categories because of various factors. That's over 65%. The big thing is, what do you do when you fall in the intermediate, the 5 to 65%? How do you handle that? The other note is that anytime you assess somebody with a nodule, please try to get older x-rays and imaging, because that's going to be huge in determining whether this is something benign and has been there for 10 years or something that's growing and concerning. There are many risk prediction models available to clinicians to help risk stratify nodules. Brock University Calculator and the Mayo Clinic model are the most commonly used. Approximately 10% of nodules greater than 8 millimeters are lung cancers. And the biggest predictors are the size and the current smoking history. There are various tools that also help you in management of lung nodules. The Lung RADS is a screen-associated nodule management assistance developed by the American College of Radiology, and a positive screen is identified as a nodule that's either equal or greater than 6 millimeters. And if you look at Lung RADS, it helps you manage nodules based on their size and their characteristics and how suspicious they are. And it'll tell you how quickly you need to get a follow-up scan. The other guidelines that's available, these are for incidentally detected lung nodules that are also a huge thing. And these are the Fleischner modified guidelines from 2017. These are specifically for solid nodules, whether they're single or multiple. And based on the size, if it's less than 6 or greater than 8, you'll have many recommendations in terms of when you should think about a CAT scan or a PET scan. Fleischner guidelines also have management recommendations for subsolid nodules like ground glass and part solid. Thing to note is that ground glass are typically slow growing. So, some of the follow-up is in years, and the part solid indicates invasiveness like we discussed. And therefore, if it's persistent part solid greater than 6 millimeters, they should be considered very highly suspicious. So in summary, the risk of malignancy increases with the size of the nodule, greater than 6 millimeters solid component, upper lobe location, spiculated borders in numbers up to 4 nodules. Part solid ground glass nodules have a higher risk of malignancy compared to pure ground glass nodules. An evaluation of a pulmonary nodule is based on risk of malignancy and patient's characteristics and preferences for diagnosis and intervention. So when you go to the management algorithm, first you're looking at the radiology. We're all looking at how big the nodule is, where the nodule is, how suspicious. Then you assess the surgical risk of the patient. Is it low to moderate or is it high? Then you consider the probability of cancer. Is it very low and just, then you may just want to do CT surveillance. If it's low to moderate or high, then think about additional imaging that can help you, like a PET scan or additional CT scans. And then you think about the intervention that this patient might need. Is it surgical resection, a biopsy, or other modalities like radiation? When you think of a biopsy of a nodule, when do you do it? And these are some of the criteria you can use to think about biopsying a nodule. One is if there's a discordant pretest probability with imaging. That is, you think the risk to the patient is low, but gosh, that nodule really has high risk features, or vice versa. If the probability of malignancy is low to moderate, and you don't know what to do with that intermediate bucket. If the patient is a high surgical risk, and you want to either minimize that, or you really want to be 100% sure before you put them at that risk. If you have a suspected benign diagnosis that requires specific treatment, say it's an inflammatory granuloma or an NTM or some other reason, the treatment totally changes, or if the patient prefers it and says, I really want to know for sure before I do anything. The various techniques that are commonly performed are CT-guided biopsies, just done through the chest wall by interventional radiology typically. There are peripheral radial ultrasound-guided techniques that navigate to peripheral lesions, and we can biopsy them using various tools. There are electromagnetic navigation platforms that use a GPS-type software to help navigate to peripheral lesions. And then the latest are the robotic platforms, such as ION and Monarch, that help biopsy peripheral lesions. The other thing is staging. So what is staging? Staging is trying to figure out how severe this cancer is, where it has spread. And the methods for staging include non-invasive, like a CAT scan or a PET scan or MRI brain, or invasive methods where you're using endobronchial ultrasound or endoscopic ultrasound to stage the mediastinum, or surgical techniques like mediastinoscopy or mediastinotomy. In terms of imaging, a PET scan is recommended for non-invasive staging of mediastinum and is often performed. While it is sensitive and can be pretty specific and has a greater accuracy, it also has false positives because it cannot distinguish between cancer and inflammation or infection. So you really have to use it and interpret it in the right way based on the population. It is strongly recommended in clinical stage 1B to 3B in patients who you're intending to cure. And in clinical stage 1A, it's considered adequate for staging, and you don't need any other modality when you're thinking about surgical resection. The other non-invasive methods, like we discussed, are MRI brain or CT abdomen, looking for distant disease. Invasive staging is often done with endobronchial ultrasound. It's usually done when you have large tumors greater than 3 centimeters, where the risk of nodal metastasis is higher. It's done in centrally located tumors because you again have a 20 to 30% risk of nodal metastasis, even if there are no suspicious nodes on non-invasive testing and imaging. When you have suspected hilar involvement, oftentimes there can be up to 30% risk of mediastinal involvement as well. And if there is a high suspicion of nodal involvement, a needle technique such as endobronchial ultrasound is recommended over surgical staging. And typically, we start with the potentially higher stage lymph nodes and work our way down to the lower stage lymph nodes to prevent cross-contamination. Nodes greater than 5 millimeters are usually sampled, although we all have seen patients with even smaller nodes that are positive. And this is just for reference. You can look at it in greater detail, but the 8th edition of the TNM staging is what everyone uses to try to characterize the tumor based on radiologic features and invasiveness. Then you characterize the lymph node involvement and give the staging from N0 to N3. And then you look for distant metastatic disease. And all of this gives the patient a T stage, an N stage, and an M stage that then tells you what stage of cancer they have. For small cell cancer, you think about it more as a limited stage or an extensive stage disease based on where the tumor is confined to and the nodal involvement. So in summary, lung cancer staging is critical for prognosis, treatment, and even eligibility into clinical trials. Mediastinal staging is still recommended in certain cases of a negative mediastinum by CT or PET. And invasive mediastinal staging with endoscopic needle techniques is used as first line. At this point, I want to say thank you to everyone, and I'm open for any questions.